All right, welcome back, everyone. We're running about 15 minutes late, so I appreciate everyone's patience. We'll now hear from our second panel. The panel will discuss opportunities and barriers for STI prevention and control at the state and local levels. Again, for each panel, just like this morning, we'd like speakers to remain seated until their presentation. But then at the Q&A, we'll have the entire panel at the table up front to take our questions. So first I'd like to introduce Gretchen Weiss. And Gretchen is directing HIV, STI, and viral hepatitis for the National Association of County and City Health Officials. Thanks very much. Do we have her slides cued?
Yeah, I don't know, actually.
Does this need to be pointed at?
It looks like we don't have them cued.
Oh, okay.
Let's see. In a moment.
Yeah.
I wonder if I can figure it out. I'm sure it's cute. It's just
It's up. I just don't know how to switch the.
switch it.
No, that's all right.
I thought we were ready. Oh, let's just press escape. That doesn't do anything. I think it's being controlled back there. That's the problem. Oh, there.
Oh, there we go.
There. Okay, now we're in business.
Oh,
We almost were there. Try again. We had them. There we go.
Okay, there we go. All right, well, thank you so much to the committee for having me here today. I'm Gretchen Weiss. I'm the director of the HIV, STI, and viral hepatitis program at NACCHO, and I will be speaking about the local health department perspective. So NACCHO's mission is to improve the health of communities by strengthening and advocating for the nation's nearly 3,000 local health departments. And I'm going to spend the first few minutes of my presentation presenting some data from NACCHO's profile of local health departments and Forces of Change survey to really try to paint a picture for the local public health system and local health departments and the context in which STI prevention and control strategies are being implemented. And then I'll speak to some of the opportunities alongside NACCHO's work. So while there are 3,000 local health departments across the United States, about 50%, 51% of the U.S. population is actually served by 6% of all local health departments. And so we have the majority of local health departments, 62% of local health departments serving jurisdictions with populations of less than 50,000. So this is just thinking about that distribution of the number of local health departments and the size of the jurisdictions that they serve, and therefore the capacities of local health departments and really the great amount of variation across the country. And this is that same information just represented on a map of the United States. Local health departments also vary in relationship with their state health agency. So some local health departments are local or regional units of the state health agency. Others are agencies of local government. Others are governed by both state and local health authorities. And then sub-states also include health departments with more than one governance type. And this is really important to be mindful of in program and policy development, as the context in which our strategies, our plans, and funding are being implemented are really quite different. In terms of the size of the workforce in local health departments, there are approximately 147,000 local health department employees and 133,000 FTEs in local health departments. And the number of staff within our local health departments vary significantly. Again, I'm really trying to build this case for the varying degrees of capacity for local health departments in terms of implementing STI prevention and control activities. So we see that for, on average, for local health departments that are serving populations of less than 10,000, they have 8 staff, and for those that are serving populations of greater than 1 million, they have 736 staff on average. Now, NACCHO's profile of local health departments does collect information about the number of local health department employees working in specific positions. We do not collect that information through this profile for DIS. However, I wanted to share information that we collected in 2016 when we undertook an effort to enumerate the DIS workforce and identified 1,661 DIS positions and 402 DIS supervisor positions. So a relatively small percentage of the total local health department workforce, and I think as we've already heard today, very critical component and one that we can all agree needs increased capacity. In terms of the screening and treatment services provided by local health departments, 65% of all local health departments screen for STDs and 63% provide treatment for STDs. However, when we look at local health departments that are serving populations, larger populations greater than 500,000, we do see that this increases pretty significantly. So 92% of local health departments serving large jurisdictions are screening for STDs and 89% are treating for STDs. In terms of surveillance and informatics capacity, not surprisingly, the vast majority of local health departments conduct epidemiology and surveillance for infectious diseases, but very limited percent of local health departments actually employ epidemiologists or statisticians, and even fewer employ information systems specialists. This, again, as is a theme here, when you look at the health departments that are serving larger jurisdictions, nearly 100% of those health departments that are serving over 1 million jurisdictions a size of 1 million plus employ epidemiologists. So there is quite a range here, but in terms of broad-based epidemiological capacity at the local level, it can be relatively limited. And when we look at the implementation of information technology systems, we see that 50% of all local health departments are implementing electronic lab reporting, 37% are implementing electronic health records, and less than 20% are engaging in health information exchanges. And so, as we've heard today, when we think about the capacity to use data, to interpret data, to access data, we really need to be thinking about the surveillance and informatics capacity in our health departments, both state and local. So, over the past decade, local health departments and really, across all levels of public health, we've seen significant budget cuts and job losses. So since 2008, local health departments have eliminated a cumulative total of over 56,000 jobs. And while we have seen these job losses taper off over recent years, which is seen here on the right in the bar graph, and we've seen the percent of local health departments that are reporting decreases in their budgets on the left-hand side. That's the light gray line. That's the percent of local health departments reporting decreased budgets. So we have seen this taper off over recent years, but I think what's really important to recognize here is the cumulative impact of these budget cuts and job losses and what this means for the real deficit of our public health infrastructure at the local level. So when we're thinking about innovation and we're thinking about new strategies and new approaches to addressing the STI crisis, thinking about the need to infuse resources into some basic public health functions and really rebuild that infrastructure, reestablish that workforce to do very critical work.
Gretchen, before you go on, could you just point out the previous slide? That very faint line on the left at the top, we can't read that. What does that say?
So, I should say, that is the faint line there is the percent of local health departments that are reporting decreases in budgets. So that is about 20% in 2018. And that is down from nearly half of local health departments reporting that they had their budget decrease. Yeah.
I'm sorry. Ned Hook, are those year-to-year changes, so it's cumulative decrease?
This is the percent of local health departments each year reporting that they're, so yes, so to rephrase it, then if it's 20% one year and 20% the next year, it's 20% more. Yes, it is cumulative. So some of these 20% in 2018 were also part of those reporting budget decreases in previous years. So the impact of budget cuts and job losses, of course, has effects on all aspects of the work that local health departments are doing. And we do have some information about the impact specifically on STI programs. So in partnership with colleagues at the CDC, we conduct what we refer to as the infrastructure survey. This was last conducted in 2013 and 2014, and we fielded it again last year. And so hope that either later this year or early next year, we would have available the results from this survey. But here we had 62% of health departments reporting that their STI budgets were cut between the fiscal years of FY11 and FY12. And in terms of thinking about some of the impacts of those budget cuts, reduced clinical services, having a negative impact on the provision of partner services, and certainly encourage, I think have shared that publication with the committee. Some more recent data, NACHO maintains a sentinel network of about 150 local health departments across the country that have volunteered to be part of this group to respond to brief queries on about a quarterly basis to just give us a sense for what's happening on the local level. And so about 2 years ago, we asked what they were continuing to experience in terms of budget cuts and job losses, and saw that 81% reported stagnant or decreased funding levels over the past year. Now, of those 81%, many were reporting stagnant budgets as opposed to decreased. But when we looked at those that reported budget cuts, where were those reductions most likely to occur? They were affecting public health nurses, disease surveillance, STI partner services, and HIV testing. So we work in close partnership with many of our local health department members on our STD activities, and that work really highlights the opportunities that are happening at the local level through the commitment, the interest, and really the innovation that is taking place. And so I'll address some of NACHO's activities as well as the work of local health departments at the same time here. And so we work to provide capacity building assistance, facilitate peer learning, and identify best practices for STI prevention and control. And we've got some examples of this work here. I would call attention to, for example, the STI Express Visits Initiative, where for about 2 years now we've been working with STD clinics across the country that are looking at cost-effective approaches to increasing rapid testing and treatment. We've undertaken a number of demonstration projects. We're currently working with about 5 local health departments across the country who are looking to address high-risk substance use through STI clinics. We've examined rapid syphilis testing in non-clinical settings and implementing sexual health campaigns, and certainly efforts to support the DIS workforce, and have really relied on the work that is happening at the local level, what our members, what local health departments are doing in these resource-constrained settings to continue to innovate and address the STI crisis in their communities. NACHO also undertakes a number of communications activities to ensure that local health departments have the latest information on developments and innovations in the STI field, a number of efforts to maintain the situational awareness of what is happening on the ground and really being able to share that with other key stakeholders. And then our efforts to inform policymakers about the role of local health departments in STI prevention. And lastly, in terms of local opportunities, I did want to highlight some local opportunities related to PrEP implementation. So in 2015, so this was a few years ago, and it was only about a year after CDC released its guidelines for PrEP, we conducted a national survey of local health department engagement in PrEP implementation and identified that 29% of local health departments reported engagement. And making referrals for PrEP was the activity most frequently reported by local health departments that were engaged in PrEP implementation at the time. Now, while only 9% of local health departments reported delivery of PrEP from a health department clinic, when we asked about optimal role for local health departments in PrEP delivery, we saw that 27% reported delivery of PrEP from a health department clinic as an optimal role. And the last two bullet points speak to intention to expand engagement in PrEP implementation. And I would say that local health departments' intentions and expectation to expand their engagement of PrEP implementation has certainly increased since 2015. But as we've already recognized today, there are a number of opportunities looking at the intersection between HIV prevention approaches and our STI prevention and control approaches, and certainly PrEP delivery offers one of those critical opportunities. And so lastly, I want to end by saying, and I won't read through this slide, but really put this here for the committee and others to consider about local health departments as community health strategists. This is something that I frequently come back to when talking about the role of local health departments in addressing the STI crisis or the HIV crisis, the hepatitis crisis, you name it. And this is really thinking about what is the role of a local health department as a community health strategist. They are certainly not the only health strategists in their jurisdictions, but what is that role to be a high-achieving health department today and moving forward? And I think a lot of these roles, when we think about what it's going to mean for how we access data and utilize data, how public health is interacting with the healthcare community, a lot of these roles are really captured and instructed by this concept of the local health department as the community chief health strategist. And that is what I have for you today. Thank you.